So good morning, everyone. I'm Representative Kathy Abercrombie. I am the co-chair of the Human Services Committee, along with my Senator, Marilyn Moore. We'd like to welcome you and aging to this informational forum around Medicare. I know it's a little out of our lane because we don't normally work on Medicare issues because that's federal. We're Medicaid, which is state, but we thought it was a good opportunity to talk about Medicare, some of the changes that are going on in the Medicare world, because it's really important for our constituents to understand the difference. So with that, I'll turn it over to my co-chair, Senator Moore, for any opening remarks.
Oh, well, I'd just like to say good morning to everyone. I had the privilege of speaking to Mrs. Stein and her partner in this great discussion, warmed my heart. I look forward to what we hear today. So thank you. Good morning. Thank you, Representative Abercrombie.
Thank you, Senator. And to our rankings on human services, I'm not sure if they're on because sometimes you can't see everybody. Is Senator Purcell here? I don't see him. Okay. Representative Case? I don't see him. So moving on to our counterpart, the Aging Committee, I'd like to welcome Senator Miller. Do you have any opening remarks, ma'am?
No, not really. I just want to say good morning to everyone. And I want to thank my co-chairs, the Honorable Kathy Abercrombie and Senator Moore, as well as the ranking members. I just want to say thank you to the panelists for willing to come today and give us a host of information. So again, good morning, everyone. And I'm looking forward to learning a lot more about Medicare.
Thank you, Senator. And the House member, Representative Garibay, had a conflict this morning. She was not the chair when we set up this forum. So she's going to join us as soon as possible, and then we'll introduce her. And then I'd also like to ask for any opening remarks from Senator Posado, if he's on. And Rep. Wilson.
Good morning, everyone. It's bright and early, nice and chilly, 4 degrees out here in Litchfield. I'm glad I didn't have to drive outside to come to Hartford today. But this should be interesting. In my background, I have a lot of experience with Medicare. And I guess being 75, I'm kind of qualified to be on the committee and learn more about Medicare. So I look forward to today's information. Thank you.
Thank you, Representative. Senator Moore, I see your hand up, ma'am.
Yes, Rep. Wilson, that was my sentiment yesterday on the call. I was glad we didn't have to leave and drive to Hartford. I just wanted to mention, I thought Representative Abercrombie, you mentioned yesterday, it'd be good for the aides to listen in. But because this is a webinar, the link is unique and they can't sign on.
Senator Moore,
Yes.
This is a streaming on YouTube, on the Human Services YouTube channel, and I also believe CTN is covering it.
All right, thank you. I just got a text from someone.
You're welcome.
Thank you.
Thank you, Senator. Yeah, I think it's important for our aides to also be able to listen in on this because they are the first line of contact with our constituents. So I agree with you 100%, and thank you for raising that issue. With that, let's start this forum because I know everybody's waiting to get the information. Our first speaker is Judy Stein, who is the Executive Director for Center for Medicare Advocacy. Just so people know, just in case some people aren't aware, the state of Connecticut has a contract with Judy Stein, and part of her role is to get funds returned when Medicaid pays first, and they're not the first payer. Medicare is the first payer. And I just want to say that we are really, really fortunate to have Judy. I would highly recommend my colleagues to keep her number and her staff because I have had the pleasure of working with Judy for many years, and there's nobody that's more versed on Medicare than Judy Stein. So I really want to thank you for taking time out of your schedule to be here today and kind of walk through what is Medicare and who is the first payer under Medicare, and then some of the changes you see coming down the line with Medicare services. So with that, I have the honor of introducing Judy, who will take it from there. Good morning, ma'am.
Good morning. Thank you so much for those kind remarks. And let me make sure you all know that the Center for Medicare Advocacy is made up of many very expert and qualified people, nonetheless, not the least of which is Kathy Holt, who is my associate director and runs our advocacy day-to-day in the Connecticut office, and is both an MBA and an attorney. And Kathy and I both focus particularly on home and community-based services. We are today going to talk about Medicare, why it's so important that Connecticut policymakers know about it, and also about our marvelous partnership with the Long-Term Care Ombudsman and our remarkable ombuds, Mairead Painter, who really is stellar and known to be so nationally. So we're delighted to be here today. And Kathy, if you'll start our slides, please. So thank you again, and thank you, Representative Abercrombie, being such a stellar ally for older and disabled people and people who need a voice in our state legislature. And I want to echo Senator Moore's comments with regard to a marvelous conversation we had, and for all that you all do for Connecticut residents. Today, we're going to be talking about Medicare for Connecticut residents, and I'm going to tell you a bit about why that is so important, about what we have to offer you and your constituents at the Center for Medicare Advocacy, and an overview of Medicare. And then Kathy's going to talk about some key issues we want to bring to your attention, and we'll both be happy to talk about our wonderful partnership with Mairead, and then she'll follow with important information about the Ombuds office. Next slide, please. So the Center for Medicare Advocacy was founded in my kitchen in 1986 after I spent 10 years wonderfully at Connecticut Legal Services, by the way. I was the attorney representing older people in Eastern Connecticut, and older people were defined as 60 or over, which sounds younger and younger to me. The Center for Medicare Advocacy is a nonprofit, nonpartisan law organization, and we work to advance access to comprehensive Medicare. So by that, we mean the full array of benefits that Medicare offers for all people who qualify for Medicare, health equity, and quality health care. That is our mission. We're based in Connecticut. Our office here is in Mansfield. And while Kathy and I are working remotely today, we have been back in and out of our office since the end of July, and we hope to return soon again. We actually, those who can work from home, returned home 3 weeks ago. We hope to be back in our office, but we are fully staffed here. Our phone is answered every day from 9 to 5 by a real live human being. We do not have an answering service. And so your constituents, which we want to keep reminding you, we're here to serve you and your constituents, can reach us every day at 860-456-7790. And I'll keep repeating this. And also on our toll-free line at 800-262-4414. We also have attorneys in Washington, D.C., and we did have an office in Washington, D.C. until a year ago, which we had to close because we were paying rent for an office we couldn't use, but we are staffed by 5 people in attorneys and MPH in DC, so that because it's a Medicare is a federal program, we can work both on behalf of Connecticut citizens, and we can bring issues to the fore at the Capitol in Washington, where we are actively involved in policy, educating our congressional delegation, answering questions as asked by congressional leaders in the Medicare and healthcare field and the aging field as well. We also have an attorney in California, Massachusetts, and New Jersey. So the center is organically grown from Connecticut, where we are, as I say, based, and it's our home. We have 20 full-time equivalents in our Connecticut office. We're staffed by attorneys Medicare advocates, paralegals, communication and technical experts, and we also have a nurse consultant who works with us to provide an array of education, legal analysis, writing, direct assistance, and broad advocacy. Our services are free thanks to the largesse of the legislature and contracts with the Department of Social Services and with Aging and Disability Services. Our services are free for Connecticut residents. And so we serve people throughout the state. We're located here in Mansfield. Why? Because, as I said, we've grown organically, and I started the center out here in 1986, but we are a small state. We can get everywhere. And under these circumstances, of course, we're often remote. We serve people equally all over the state of Connecticut. And from the problems we hear and solve or try to solve every day from in Connecticut and from around the country, but largely from Connecticut, we not only hear the experience and real problems of real people, but we develop systemic change efforts. As I mentioned earlier, we do a lot with the congressional delegation and with others who are leaders in health and aging policy and disability policy to try and make Medicare work best for all people who rely on it. And that is true for everyone throughout Connecticut. We also, on occasion, when necessary, bring litigation. It's always against the federal government because Medicare is run or not run fairly by the federal government. And we've had many successes which have led to, I'll say, two particular things I want to bring to your attention. One is we are lead counsel and won a settlement with the Centers for Medicare and Medicaid Services, CMS, which runs Medicare and Medicaid, so that people who will not necessarily improve or improve fast enough should still be able to, for the likes of the Medicare people, administration should still be able to get Medicare coverage for home health, for skilled nursing facility, nursing home care, and for outpatient therapy. And this is a result of a settlement in a case called Jimmo versus Sebelius. And there's lots of information about this and everything else on our website, medicareadvocacy.org. So if you hear of a constituent who's been told that the Medicare won't cover because they need the services just to maintain their condition or to slow decline and they're not improving, please let bells ring in your ears and make sure you or the constituent or your staff calls the Center for Medicare Advocacy. We will try and help out. That is not true, and we are the leaders in this. We also just won a case at the Federal Court of Appeals last week, which will now allow people who are in the hospital and said to be on observation status. If they're told they're not inpatients, they're on observation status. They will now be able to appeal that as a result of a case that we won last week after almost 11 years of litigation. So we need funding desperately because our work takes sometimes a great deal of persistence, and we help about 7,000 people every year directly and tens of thousands, indeed hundreds of thousands through our systemic work. We work on Medicare coverage and appeals. That's our expertise. And we also, as Representative Abercrombie mentioned, have a contract since 1988 with the Department of Social Services by which we appeal Medicare denials for people who also have Medicaid to ensure that Medicare is not cost shifting inappropriately to our state Medicaid program, and that Medicaid is in fact the payer of last resort, which it is required to be by law. Medicaid and families should not be paying for, in this case, we appealed nursing home and home health care denials. Medicare and families should not be paying Medicaid when Medicare is properly available. And over the course of the last decades, since 1989, we have returned $400 million to the state of Connecticut from our Medicare appeals, which is a very unique program, not mirrored in other states. And this helps make sure that our Medicaid program stays robust, and hopefully that providers look to Medicare before they look to Medicaid, and that providers also don't bill families before seeing whether Medicare should be available. Next slide, please. So we have a great deal of gratitude to the Connecticut legislature and to the Aging and Disability Services Department for the funding that is provided to the center, which is for the services we provide for individuals and their families throughout the state, which is both direct assistance and education on behalf of Connecticut residents. We are also the training arm for Medicare for the Choices program. We are a long time, since the beginning, partner in the Choices program. Our staff provides the training and we provide technical assistance. So if you think of it this way, the Choices program handles a lot of questions about what's the best vehicle for your health insurance, Medicare or Medicaid, and maybe the Affordable Care Act and combinations. And we get calls when there are problems with Medicare coverage. We try and untwine them or help our partners at Choices do that, and at the area agencies on aging and all our other partners around the state. That is funded by the Aging and Disability Services, in part through funding from the Connecticut legislature, which I really cannot begin to thank you enough for. Next slide, please. So again, we are partners in the Choices program. They help with decision-making, we help with problems, and we refer back and forth between these two programs all the time. So I provide you with the Choices number here. And if there are problems with Medicare coverage, contact us first. If there are questions about what to enroll in, what's the best vehicle for your constituent, you might want to try Choices first. In any event, it's not hard to have one-stop shopping, because if you do contact the center, we will absolutely get you to the right place or your constituents through our live in-person information referral people who answer the phone, or one of our advocates or attorneys. We also are very knowledgeable and like the Choices program, provide objective information about related programs, including the Medicare Savings Program, which we again thank the legislature for ensuring that Connecticut has such an important program without an asset test. And Kathy Holt will be telling you more about that program during this presentation. Next slide, please. So what is Medicare? And let's provide a little bit of an overview about what you can know quickly, that's both not, I hope, too much to ingest and also accurate. But do know that we're around, right? So you have expertise to help people who have Medicare to rely on for access to insurance coverage for their health care. Just call us, look at our website, email us, we'll help anytime. So Medicare is the first national bedrock national health insurance program. It was enacted in 1965, and the goal was to provide basic health insurance for people who were 65 or older. And let me say that before Medicare, it's hard to imagine, but half of everybody 65 or older throughout the United States had no healthcare coverage at all. And now the vast majority, because of Medicare, have health insurance, largely through the Medicare program. This has also brought up the economic security and finances of families throughout the United States. People usually qualify for Medicare based on age, having attained the age 65 and having paid into Social Security for 40 quarters, not necessarily consecutive. So just as a general rule, most people qualify because they've paid into Social Security and they've attained age 65. It is not based on income, unlike Medicaid, which we in Connecticut often refer to as Title 19, sometimes Husky, which is based on income. Medicare also covers folks who are less than 65, that says greater or equal to 65, which is true, and certain people with disabilities or end-stage renal disease. So let me rephrase that because it wasn't artful. People qualify for Medicare because they're 65 or older and have paid into Social Security, or they have significant disabilities and receive Social Security disability benefits for at least 24 months, or have end-stage renal disease. So what is unknown to a lot of folks is that Medicare can be, and about 20% of people with Medicare are under 65. They can be covered by Medicare. Medicare covers hospital coverage, nursing home care, also known as skilled nursing facilities or SNFs under the Medicare rubric, home health care, doctor services, durable medical equipment, such as a wheelchair, a walker, a hospital bed, prosthetics, orthotics, hospice care, increasingly prescription drug medicine, some preventive services, which have increased and are usually paid fully with no copay as under Medicare as a result of the Affordable Care Act, and some vaccines. Medicare is available in two basic ways. One is through what we refer to as the traditional, or Medicare often calls it the original Medicare program. You'll sometimes hear this referred to as the fee-for-service program. We don't like to call it that because the fact is that even under the traditional original Medicare program now, providers, except for physicians, are almost always paid under some form of a capitated rate, not just a fee for an individual service. People can also get their Medicare through private Medicare Advantage plans, which are offered by dozens of plans here in Connecticut. And there are pros and cons, and this is something that both Choices and we can help people navigate, because this has made the program and the choice of how to get your Medicare far more complicated. Medicare Advantage should cover at least as much as original or traditional Medicare and follow the same rules, regulations, and law as Medicare, as traditional Medicare. It can provide more, but should not be providing less. I want to give you an example. People in nursing homes are entitled under Medicare law to up to 100 days of coverage every benefit period. That can be complicated, but a benefit period can cross years. It's not based on a calendar year. It's not based on a particular diagnosis. It's based on a person having needed and then no longer needing skilled care for 60 days and then returning to a nursing home with a 3-day hospital stay usually. But let's just say for this purpose, Medicare covers up to 100 days of skilled nursing facility, nursing home coverage in a benefit period. And if one of your constituents has confusion about that, which it can be very confusing, contact us. Sometimes people in Medicare Advantage plans, we hear, are told, or the nursing home is told, that they can only get 14 days of coverage, and then it'll be reviewed, and then maybe another week. We want you to know that there is no more limiting coverage under Medicare Advantage law than under traditional Medicare. And this is a place where we hope to work with increasingly with both Choices and with the Ombuds program to ensure that people get what they're eligible for from the Medicare program in general and the nursing home benefit in particular. Also, you know that Medicare for a number of years now has covered prescription drugs under what's known as Part D, which is also available through private plans. We, by the way, in addition to having all this information on our website, medicareadvocacy.org, have a wide array of physical brochures and flyers and assistance that can be of assistance to you and your constituents. We have links to that material at the end of this presentation, and we'd be happy to send brochures, or you can print most of this information off our website. Much of it is available in Spanish as well as in English. Next slide, please. Medicare is an insurance model. Excuse me, I'm just looking to make sure that I'm covering the right slides and knowing when I should hand this over to Kathy. So it's an insurance program. So like with any insurance program, it covers some of the cost of some healthcare, right? There are rules and regulations. And just like you need to look at your policy or know Medicaid rules in order to know what coverage is available, you also need to know that in order to know whether you're being told coverage isn't available when maybe it should be. At base, the care must be what's known as reasonable and necessary for an illness or injury, for the diagnosis, treatment, or rehabilitation of an illness or injury in order to be covered by Medicare. There are increasingly some preventive services that are covered, and thanks to the Affordable Care Act, those services have increased and are largely paid for in full by Medicare. That includes things like prostate cancer screening, mammographies, glaucoma screening for people at risk. And again, it's a wide array now, fortunately, and you can find that list on our website. There are premiums, deductibles, and copays for Medicare. No free lunch here. Even if you've paid into Social Security, people will owe premiums, deductibles, and copays, and they've increased over time. And this is one of the reasons why the Medicare Savings Program is so very, very important. And Kathy Holt will speak to that in a little bit. One of the reasons here, one of the things here I also want to focus on is let's not silo. Remember, your constituents can qualify for both Medicare and Medicaid. They can qualify for Medicare and the Medicare savings programs. And we can help you and your constituents understand how those programs are intertwined and how they may be able to appropriately maximize their coverage under Medicare so they don't use Medicaid, which is better both for the state and for a family, and also so that they may be able to get help with their premiums, deductibles, and copays if they qualify for the Medicare savings programs or for Medicaid. I want to reiterate here that a person does not need to be able to improve in order to get coverage for home care, for outpatient therapy, or for nursing home care, and they are often told otherwise. So if you or your constituents hear that, assume it's not true, give us a call, and we'll try and untangle it. Do the best we can to open doors to healthcare for people who rely on Medicare. And that's because we don't want them to go without the care. We don't want them to pay themselves for care that is necessary. We don't want Medicaid paying or people becoming qualified for Medicaid because Medicare is being inappropriately denied. We want to make sure that Medicare meets its promise for all people who qualify for the program. And with that, I'll turn it over to Kathy. Thank you.
Thank you so much, Judy. And hello, everyone. We're thrilled to be here. And Judy Stein is a state treasurer and a national treasure. We just love working for Judy and being a part of the Center for Medicare Advocacy. It's an inspiring place to be, and we're just grateful to you to be able to share our work in a way that hopefully will help all of your constituents and everyone in the state of Connecticut. I will just say generally, as I was listening to Judy, Connecticut is a fabulous state to be in if you are a Medicare recipient. You have the ability to have not just us. I'm not saying that about us necessarily as the combination of the commitment from the Aging and Disability Services, the Fantastic Choices program in Connecticut, the marvelous Medigap program that's offered through the state of Connecticut, and the rich MSP benefits that people are able to access. So I'd like to talk about some of those now, but mostly I want to focus on what's happening with, as Judy mentioned, there's been some cost shifting from Medicare onto Medicaid in some programs. And so today my highlight will be on home and community-based services and the home health care benefit through Medicare, looking at obstacles to accessing Medicare covered healthcare. So I'll cover home health and then turn the program back over to Judy to just give a quick rundown of other issues that we're watching. So just again, to give you a sense of what is covered by Medicare in home health care. So I have 3 slides that I want to go through here that will give you a sense of when someone should qualify for Medicare home health. There's been a lot of confusion, a lot of misleading information, and we just really wanted you to know what the law says about Medicare home health care. So there are 3 criteria in order to obtain Medicare coverage. One is that you have to be under the care of an approved provider. So what does that mean? In the state of Connecticut, it's a physician assistant, or a nurse practitioner can order home health care. There's a face-to-face certification requirement, which through the pandemic has been allowed by telehealth. But the point of the face-to-face certification is to make sure that the physician, the nurse practitioner, the physician assistant has eyes on the patient and really understands what it is that they're ordering and what they need. So under the care of an approved physician is the first criteria. The second criteria is confined to home. And confined to home means an inability to leave home without a device or the assistance of another person, or leaving home is medically contraindicated, which means that someone is immunocompromised, they may have dementia, there may be a number of reasons why it's medically contraindicated for someone to leave home. And the other part of being homebound is that it requires a considerable and taxing effort to leave home. Oftentimes there's confusion that homebound means bound to the house. Essentially what it means is that as long as you're not leaving home on a regular basis, that you're leaving for short periods of time, or you're leaving for just things like going to the doctor, going to religious services, going to a wedding or a funeral or a reunion, those are allowed under Medicare. You can still get home health care and still be considered homebound. And then the third criteria is that you need some sort of skilled service. And what does that involve? So that means that you have to have the need for a nurse, a skilled nurse, or physical therapy, or a speech language pathologist. So having the need for a skilled service at least one time in a 60-day period would allow you to be covered by Medicare under home health. What's important to note is there is no duration of time limitation in Medicare. So what that means is as long as you continue to meet this criteria, you can be covered by Medicare for home health care. So once you are covered by Medicare, what are the services that you can receive? So as we mentioned, skilled nursing or skilled therapy. What's important to note, a little nuance in this, is that occupational therapists are not allowed to be the only skilled service to start care. But once care is started by either a nurse, a physical therapist, or a speech language pathologist, then the occupational therapist can provide services and continue to be the only skilled services once services are started. So once you have a skilled service, that opens the door to what Medicare calls coverage for dependent services. And dependent services can be home health aides, medical social services, and medical supplies. Those are what are covered by Medicare. So just focusing on the home health aides, because what we see often is that home health agencies may provide the skilled services, and then if someone has Medicaid, they may say, okay, Medicaid can provide the personal care assistance. And so when we look at Medicare coverage, we want to make sure that people understand exactly what the Medicare benefit looks like. So for home health aides, you can receive, combined with skilled nursing, up to 28 hours a week. So you might look at that and say, where did Medicare come up with 28 hours a week? Clearly, that means up to 7 days a week, 4 hours a day. And then subject to a case-by-case review, Medicare covers up to 35 hours a week. Again, up to 5 hours a day, 7 days a week. What's important, again, to note about the difference between what Medicare covers for a home health aide is that the services have to be hands-on personal care. So hands-on personal care is bathing, grooming, transferring, feeding, helping someone do their laundry if, their personal laundry, helping someone with moving from the bed in the morning to getting ready for the day, getting set up in a chair maybe for the day, depending on their circumstances, and then doing the reverse in the evening. So those are the types of hands-on personal care. Medicare doesn't cover chore helpers, transportation, or those types of services. So I'll turn the program back over to Judy, so Judy can talk about other Medicare issues that we are watching.
Thank you so much, Kathy. And so everyone knows, we work closely with the home health provider community and do everything we can to make sure that
Judy?
people are, I see Representative Wilson has a question. Shall I
I was just
answer
going
that?
to say, Representative Wilson, can we wait till the end of the presentation and ask questions then?
Sure. Okay. Thank you.
Thank you, sir. Proceed, Judy.
Sure, my pleasure. Thank you, Kathy Holt, for a wonderful overview of home health care. And it's really one of our heart missions to make sure that people can stay at home with adequate and proper care so that they remain safe and healthy there. And if they have Medicare, we'll do our best to make sure that that is provided as the law intends. It is a challenge. We understand that there are staffing problems, but this has been an ongoing problem way before COVID, that Medicare's promise hasn't been met. And we want to do everything we can to make sure people don't go without the care, if at all possible, that Medicare should cover. So what are some other issues that are important and we want you to know about? One is what you may have heard from your constituents or in your own life, hospital so-called outpatient observation status. And I mentioned this earlier in my remarks. This is a situation where someone is in the hospital. They may be there for one night, sometimes 2 nights, or we've had people 12 nights in the hospital, but they are told, we hope they're told, that they are, because they are entitled to notice by state and federal law, that they're being considered on observation status, and that this is an outpatient classification. It's a billing classification, but it has very significant ramifications potentially for the patient. There are a number of those ramifications. One of the first, and Mairead, I'm sure, is unfortunately familiar with this as well, and most difficult, is for people who need to go to a nursing home after hospitalization. They may not be able to obtain any of those 100 days of Medicare coverage that I talked about earlier, because Medicare requires a 3-day inpatient stay in order to receive nursing home coverage under Medicare law. It's interesting to note, as we lawyers look at words carefully, that this was originally mostly being called observation status. And then over the years, we noticed more and more that it was being referred to as outpatient observation status. And that we came to find meant that people were not able to get nursing home coverage because they need that inpatient stay in the hospital first. That became a major problem for Connecticut clients. We brought a number of individual appeals and succeeded with them, showing people were receiving a hospital level of inpatient care. But then the federal government declared that there would be no appeals of this issue any longer. And so this is an example of where, based on patterns of problems that we hear about from our calls and contacts here in Connecticut, we thought this needs systemic change if at all possible. So we continue to educate, we continue to help individual families as best we could. We worked with the state, which issued a requirement that hospitals give notice to people who are in the hospital in observation status for 36 hours or more. We work with the federal government, which eventually Congress requires that people get notice after 48 hours. And we worked with our congressional delegation, and Representative Joe Courtney, our fine representative here in the 2nd District, has introduced legislation 3 separate occasions to count all time in the hospital, however they bill it, to meet this 3-day inpatient stay requirement so people can get nursing home care. Finally, we also brought litigation. Now, let me say that litigation is no way to run a railroad. It costs us a lot of money to bring these cases. We finally, in this case called Barrows, who's a woman and her husband from New London, Miss Barrows, her husband was denied Medicare nursing home coverage because he was said not to have been in the hospital in an inpatient status. I remember her brilliantly saying, well, then who the heck was I visiting in the hospital? 11 years later, after being in district court, having a trial, and being at the federal appeals court on 2 separate occasions, we last week won that case, Barrows versus now Becerra, the Health and Human Services Secretary, and people are now entitled to an appeal, again, to an appeal if they're put on observation status. That's new news. And so if you hear from constituents or maybe hospitals in your district confused about this, or from nursing homes, people can appeal observation status classifications. The process isn't set up yet, but the government has been ordered to create one. Another major issue I mentioned earlier is that there's what we refer to as the improvement standard myth, and that is long-standing urban and rural legend that people have to be able to improve in order to get Medicare coverage. And that is not true. And we brought a case on behalf of an individual, Ms. Jimmo, and 5 other individuals, and also 5 organizations, including the National Multiple Sclerosis Society, United Cerebral Palsy, Paralyzed Vets of America, the Alzheimer's Association, and the National Committee to Preserve Social Security and Medicare. That case, Jimmo versus Sebelius, resulted in a settlement. We are still working hard to implement it to make sure that particularly our residents here in Connecticut are not denied Medicare coverage in the SNF, that's the skilled nursing facility or nursing home, home health, or outpatient setting, on the grounds that they aren't improving, because Medicare is equally available for nursing and therapy services and the array of care that comes with that, if they need that care to maintain their condition or slow decline. This could be particularly important for younger Medicare beneficiaries who qualify due to a disability, and also to people of any age who have an ongoing chronic condition or illness or injury that will not, in fact, improve or improve quickly. We hear about these issues still. Please be in touch with us. We are in touch with the current federal administration, which just in December 2021 sent out another notice reminding providers that this is true, that people don't have to improve to get Medicare coverage. Now, in nursing home, there is coverage for up to 100 days during a benefit period, as I mentioned, and that's complex enough that just call us if you're not sure if your constituent's in a new benefit period. And in those cases, the person must need daily skilled care in order to qualify for Medicare coverage. What does that mean? That means nursing or or therapy combined 7 days a week, or therapy alone, be that speech, occupational, or speech language pathology services 5 days a week, or a combination of therapies 5 days a week. The person needs to be able to need and receive daily skilled services for Medicare to cover the nursing home stay, as well as having that prior inpatient hospital stay. Sometimes we have to fuss with the program to make sure they understand and have read the medical record properly to show where the daily skilled care happened. Sometimes providers are not used to the fact that therapy can be the triggering service. I've handled a case just last year where the nursing home had told the family that, yes, there were 5 days of therapy, but it was speech therapy, speech language pathology services. And that's not what they see that often. So they weren't aware, did not know that qualified the person for Medicare coverage of the nursing home stay. We do a lot of work regarding residents' rights, including focusing on visitation. We work closely and increasingly closely with Mairead Painter and her wonderful team at the Long-Term Care Ombudsman program, where we have developed, again, fortunately, due to the legislative grant of income from the last legislative session, we are now formulating a very definitive partnership, working even more closely with the Long-Term Care Ombudsman program on resident rights that we bring our expertise to, and Mairead and her folks bring their incredible dedication and expertise to. We work all the time to make sure that coverage denials are not left intact if they are not appropriate. You can contact us for a case review. We will go over it with family, with you, with your staff, with the patient, him or herself. Just contact the Center for Medicare Advocacy, and also look on our website, which you see here again at the bottom of every slide, medicareadvocacy.org. The best friend of a patient is the provider. If the therapist, if the nurse, if the doctor, PA, physician's assistant, nurse practitioner believes the care is medically necessary, and they will attest to that, then we can tell whether they meet the federal regulation and rules and make a very good case for Medicare coverage. Kathy, now I'll turn it back over to you.
Great. So I want to say a few words about the Medicare Savings Program. I talked about how critical it is for so many patients. This year, the Medicare premium for Part B Medicare services went up to $170 a month. That's a lot of money. And we get a lot of calls at the Center for Medicare Advocacy about people who have let their Medicare lapse because they haven't been able to pay their premiums. I took a call last year from a teacher, a retired teacher, a woman who had worked her whole life in Connecticut as a teacher. And she had let her Medicare lapse because she had to choose whether or not she was going to pay other bills or continue to pay the premium for her Medicare. And we were able to get her reinstated. It's been difficult, as you may know, working with your constituents about Social Security being remote and being able to access their offices and their services. But we were able to get this particular individual updated to Medicare. And then when we took her to Choices to do a screening to see if she qualified for the Medicare Savings Program, which would pay her Medicare cost sharing, and in her case would pay her premiums, her deductibles, her coinsurance, and her copays. She qualified because she had income of less than $2,600 a month. And she had no idea. There was no way for her to have known that prior. And what we find, and statistically, about half of the people who qualify for the Medicare Savings Program in Connecticut don't even realize that there's a program that they can turn to that will help them. So we're doing our best. It was one of our priorities last year to help Choices get the word out. We've done a number of fact sheets, information. We've done an infomercial. We've done everything we can think of to provide resources to help people and people who help people to understand about the value of the Medicare Savings Program and how it can make such a difference in people's lives. So from that standpoint, again, at no cost, the Choices counselors review the qualifications and help people to do the applications for all of the Medicare savings programs. We don't do applications at our office for the programs. We can look at and evaluate whether or not someone would qualify, but for the most part, the folks at Choices have access to all of the information that would help to do an application. So we just encourage everyone to support the program. We thank the legislature for everything that you've done to make this such a robust program for people in Connecticut who are most vulnerable and most need the services of the Medicare Savings Program. And there's information on this slide about contacting Choices. We expect the rate changes to come through at any point in time. We're already into February, and those rates usually change in March, and with inflation, we expect those to increase significantly. So if someone may have been screened in the past, it's important that they be re-screened to see if they qualify for any of the 3 programs in the Medicare Savings Program. Thank you. Judy?
Well, thank you so much. And now just a little bit more about what we hope we can help you and your constituents with. And again, I reiterate Kathy's gratitude for what Connecticut does to make sure people can do the best we can do to ensure that people can access Medicare and the healthcare they need, including through our Medigap program and Medicare savings programs. Here are some specific Connecticut resources available on our webpage at medicareadvocacy.org. We have a Connecticut section. Other CMA Center for Medicare Advocacy Services, which are free of charge for Connecticut residents. Again, thank you to the Department on Aging and Disability Services and the Connecticut Legislature. So we provide evaluation, legal assistance, and advocacy for rightful Medicare coverage. We will appeal inappropriate Medicare denials, see families through the process, and speak in a non-adversarial way with providers whenever possible to see if they will provide the care and let us figure out the Medicare component. I often say to the crew I work with, you know, you need to have the words and the music right. And we try not to be in an adversarial situation, but rather to work things out if possible. For Connecticut lawmakers, we can provide you with this kind of expertise. We are more than happy to participate in virtual or actual town halls and health fairs. We used to go out all the time. State's not that big. We can get around it and back to do our other work, but we will provide and have provided remote town halls, both for legislators and for the congressional delegation. Please let know if we will join you, if that would be useful to you. We will provide such presentations, legal support, and as I said, an array of education materials. If we were to come to your health fair, we would bring things printed out for people to take home with them. We can also, and we'll soon in the next slide, provide you with links to get that material yourself, or we can send it out to your offices if that would be helpful. Constituent services, I just refer folks to the Center for Medicare Advocacy for Medicare and related issues, many of which we just discussed. And if they've reached us and we're not the right place, trust me, we will know where to send them. I mean, to refer them, because we've been around a long time and we're very, very integrated in the wonderful elder rights and healthcare rights and disability rights community in this wonderful state. Next slide, please. So here are some of the materials that we want you to know about. These are links. They're all available on our website. I want to thank Kathy Holt for being able to find these and get them up for us, because we got these done yesterday. There are others, but I want to bring these to your attention. We have the Medicare Savings Program fact sheet, which was updated last February. We'll update those figures as soon as we know what they are for 2022. That's available in Spanish and English. Most of what we provide, we can provide you in a less than 2-minute video now about Medicare savings programs. And we also write a treatise about Medicare, which I happen to have handy here. So we are experts in Medicare and hopefully in communication. We do infographics, we do fact sheets. We can, as you hear, talk to you for an hour. Unfortunately, we could even do this for days, but no one wants to listen to us for that long. But we try and gear things to the audience we're speaking to. So we have a fact sheet in both English and Spanish on Medicare Savings Program. Kathy and I just recorded a 1.71 minute program video on Medicare Savings Programs. We're going to be doing a series called Let's Talk About. This is our first one. Let's talk about Medicare Savings Programs. They'll get more polished, but we got that one out. You've a link to it. The application link for MSP is here. And here are some links to some to some home health care resources, which are so important. The infographic in Spanish and English, home health checklist, again, in English and Spanish, and just a quick fact sheet on coverage. Also, we have materials on durable medical equipment. By durable medical equipment, again, just as a reminder, that's equipment that's used primarily for medical purposes, usually in the home, but can be used outside the home, like a walker, for example, a hospital bed, wheelchairs. Next slide, please. I mentioned, and I'm proud to say, our organization has joined in a partnership with the Long-Term Care Ombudsman Program. We are working to optimize the value of each organization's expertise and resources on behalf of Connecticut's long-term care facility residents, families, and helpers. I want to do a plug for our DC office and attorneys here. This is an example of where the fact that we have expertise in Washington assists Connecticut beneficiaries tremendously. Two of our advocates there, longtime residents' rights expert, attorney Toby Edelman, and our Chiplin Health Policy Fellow, Cinnamon St. John, have done I believe it's two podcasts with Mairead. They are national experts in residents' rights and Connecticut in particular. And they are really, it is a way in which the money that we are able to obtain from the state and from the state departments is expanded by the fact that this is a federal program and we have federal eyes on the prize, getting coverage for Connecticut residents. We share resources with the Long-Term Care Ombudsman, as I just mentioned, to maximize our impact, to participate in joint education efforts. We'll be working with resident councils and residents in the year ahead in a more concerted way than we've been able to do in the past. Next slide, please. Finally, please contact us. We provide a weekly free alert called CMA Alert, a newsletter, and it's updated. It's new every week. And new information comes out on a special basis when it's important, like last week when we won that case. But it's free and it would provide you with a lot of, I think, easy to digest but important information. Contact us at communications@medicareadvocacy.org if you're not receiving this and you would like to. We also do a series of at least 6 webinars a year. We set 6 at the beginning of each fiscal year and fill in as we go along. We will have provided dozens of webinars by the end of this fiscal year, which our fiscal year ends in June. In fact, this afternoon, I'm joining Kathy and some of our other staff to provide training for Connecticut's home health providers. There's our website and our telephone number. Follow us on Facebook and Twitter. And with that, we'd be happy to take questions, and I'm delighted that Mairead is here to tell us about her wonderful Ombuds program as well. Thank you so very much.
Thank you, Judy, and thank you, Kathy. I'm already getting text messages from colleagues saying this was wonderful and very informative. So I really, really want to thank you. I know that we have never done this before as long as I've been up here. So I think that this was really a great opportunity for my colleagues to understand the difference between Medicare and Medicaid. Before we go on to our long-term care ombudsman, I think it's important for us to take some questions at this point. Before I do, I would like to just introduce the new House Chairwoman of Aging, Representative Jane Garibay. It's my pleasure to introduce you. I look forward to working with you on many issues. And if you'd like to say some words before we turn it over to questions, please feel free.
Oh, thank you, Kathy. Just welcome everyone. I'm really excited on the journey ahead in aging and working with human services. This was a wonderful presentation. I wish I had known all this years ago when my mom was on Medicare. So thank you so very much today, and good to see everyone. Thank you.
Thank you, Jane.
Thank you.
Representative Wilson up first.
Thank you, Kathy, and thanks for the presentation. I want to go back to the home care section of information, just for clarification for my own purposes. I always had the understanding that in order to qualify for either skilled care services or home care services, there had to be a prior prerequisite 3-day hospitalization. Can you clarify that for me?
Sure. I'll take that, Kathy. There is no prior hospital stay or nursing home stay requirement to get home health care covered under Medicare. Never. There was until 1980, but it was removed by the Congress. So they really meant it, right? There's no hospital or nursing home, no institutional stay. It may have an impact on whether your coverage is provided under Part A or Medicare Part B, but that should be transparent to the beneficiary. If someone is told they can't get home care because they didn't have a prior hospital stay, that's not correct. It is correct for nursing home care. You do need a prior inpatient hospital stay for nursing home care, but not for home care.
Yeah, as a matter of fact,
Thanks for that clarification.
I was going to say 2/3 of the folks who are covered by Medicare home health care are what's known as community admissions, meaning they come directly into home health care services from the community.
Okay, and then thank you. The second part of the question was, in order for that home care to be continued, is there an assessment process that has to go on? In other words, is the patient recovering, making progress?
I'll take the progress part, and then I'll talk about the recertification, let Kathy talk about reevaluations, which have to happen on an ongoing basis. But remember, you don't have to improve in order to get Medicare coverage. This is incredibly important. And the court specifically, and CMS specifically, recognize this as true for home care, nursing home care, and outpatient therapy. If a person needs skilled care, that's nursing or therapy, for the services to be safe and effective, that's the question. To provide or be supervised by a skilled nurse or therapist, not whether that's necessary to improve the individual, but rather equally to maintain or slow decline. I'll give you a very simple personal experience right now. So I have a terrible pinched nerve in my back. I'm going to therapy. Once this acute pain is gone, they told me I'm going to need to stick with them for a few more months in order to make sure that the spine stays open. That will be maintenance. If I was being covered by Medicare, both the pain relief and the maintenance afterward would be covered by Medicare because it requires a skilled therapist to provide it. And what's doubly important about that is in the home care setting, if the therapist is necessary, then that is the skilled service that, as Kathy described, triggers coverage for the home health aides as well. You do not have to improve. You do need to have a skilled nurse or therapist in place. Medicare won't just pay for home health aides, for example. Kathy, do you want to talk about the reevaluation part? Thank you.
Medicare is certified for 60-day periods. So I talked about that face-to-face certification. That only needs to happen once when the services are ordered. However, every 60 days thereafter, there has to be a recertification, meaning these services need to continue. It's kind of like a little bit of a check-in, but it doesn't have to happen. Typically what happens, that doesn't have to happen in person. So typically what happens is the home health agency realizes we're coming to the end of our 60-day approval certification period, and they reach out to the doctor and they say, recertify this care for us. And then they have a plan of care that gets approved. And so every 60 days that happens. And there have been people that have been on Medicare home health care for decades, literally, because maybe they have MS or Parkinson's or a condition which is chronic and long-term.
Although unfortunately, it's not infrequent now that after 60 days, people are told that the care can't continue. So that's another time when it would be good to call the center or tell the constituent to do so.
I don't want to monopolize this, but thank you very much. I just have had, quite a bit of experience dealing with this over the years, and I think there's a lot of information that goes unknown and unanswered. So the last question, and then I'll shut up, is this. In the selection process of selecting a home healthcare agency, would you talk about that? Because my experience is some of the larger organizations, and I won't mention names here, but I'll say the very major organizations that know how to play the game. Let me use an example. When an individual is hospitalized, for example, they are guided in a certain direction by the social worker at the facility because I believe there's conflicts of interest. Would you talk to the ability of the family and the patient to select whom they want as a home care provider?
Yeah, thank you. I'll take that. So there's a mechanism by which people can find out what Medicare certified home health agencies serve their zip code. If you go to medicare.gov, the website, the official Medicare government website, and you put in home health compare, then you will receive a screen that allows you to put in your zip code, and then it will bring up all of the Medicare certified home health agencies that serve your zip code. So you can get a sense of how many there are out there. I did this just recently for a zip code in Connecticut, came up with 25 different home health agencies. So then you have to narrow it down. And one of the things I say to families is it's better to put in a little bit of the time on the front end and just go through the criteria. So to give you snapshot information about the particular agency. Are they proprietary or non-proprietary? Do they offer all the services that you need? There's information about their quality ratings. There's information about the areas that they specialize in. So using that particular tool, you can narrow it down. There's phone numbers there. You can call the agency. You can kind of quiz them. And in the materials that we've given you are the questions that we believe should be asked about home health agency services in order for people to determine, okay, is this going to be someone that we want to have come out and evaluate my loved one for services? So there's a little bit of work that goes in on the kind of the front end to make sure that you're choosing an agency that meets your needs, but it's better to do that than to take a recommendation. We always say if you trust your provider, if you trust your doctor, the people that you're working with at the hospital, if you think that they have your best interests in mind, then follow their recommendation, but also get enough information for yourself.
Thank you so much.
Representative Wilson, you raise an excellent point that families have the freedom of choice. And sometimes they don't know they have the freedom of choice. So thank you for raising that.
That's where I was going. I knew the answer. The sad part is that the average family and person out there doesn't know any of this, and they are at a disadvantage. And when they're in their most vulnerable situation, I'm sorry, but the big guys are putting the little guys out of business. And I'll confess, I'm on a board of one of those small agencies, and our agency had to merge with a larger agency because the big guys took it all away.
Yeah.
So anyway, I'm passionate about this one.
Yeah.
No, I
You
think
raise a
you're
very important problem.
Yeah, I think you're absolutely right. I think that the more we educate our families that they have choice, right, the better it is for all of us. But I do want to say, just so that we don't start getting 1,000 emails, especially from the hospitals, I don't believe that anybody is moving someone in a direction to do harm, right? They just, in their own mind, feel that certain providers are better than others. I'll just say it that way. But you're right, families need to know they have choice and they have the right to go wherever they want and to receive the services from whomever they want. And even if these individuals are trying to move them in that direction, families need to say, yep, but I prefer this. And I think you're right, because I ran into the same situation with my own mom after she had a stroke, and more or less had to say to them, I want this facility because I think it's best for her. So families have to know that they get to stick up for themselves and what they think is best for their loved ones. So thank you for raising that. Excellent point. Representative Hughes.
Thank you, Madam Chair. And Kathy, Judy, and Mairead, y'all are rock stars. We are so honored to have your expertise advocating every day. I want to direct this on the heels of Rep. Wilson's concerns to our DC advocates. I mean, we are doing an amazing job trying to educate the public, but we also have a system, DC, that is all about like opting in and sitting down with a choices counselor and figuring out the best, plan and getting families to do their research, except that we have the 6th oldest population in the country. A lot of these people have families out of state or no families at all. And then they're faced with this, they're bombarded by ads from all kinds of stuff. And so our little ads are like, hey, meet with us, go to your municipal agent, figure out what's best for you. That's getting lost, and we're putting it on the people often with impaired cognition or ill or incapacitated or injured to figure all this out and advocate for themselves. And that's a systemic issue that we have normalized. We're like, hey, we've got all these things, and yes, but now it's changed, and now you can get home care. And it is ridiculous that we have normalized this and put this on the most vulnerable, the people with the least capacity to navigate it. I applaud our road to home care, because it is a road, it's not automatic, and nothing's automatic. And if we're going to continue with this basically opt-in system that puts it on the patient themselves or the family, if they have it, to basically have a master's degree in case management to figure it all out, then I think we really need to think about providing every elder with a case manager and having that be, Medicare paid for, rather than just saying, well, Connecticut has paid for the Choices Counselor program, but really we need if we're going to continue this really convoluted sort of you know, layered in plan, and even the Medicare savings program that they don't know they can have. And, you know, we need a case manager for every elder to understand their rights, basically. I'm just going to leave it there because it is crazy. I have people that are, you know, going into hospice that have no family. You know, they don't know that basically it's taking, you know, the legislators or whoever is aware of this to become the attorney for the person, you know, and to navigate that system. And that is not patient-centered. So I'm just saying we've normalized it. You guys are rock stars, and we need, you know, we need a better opt-out system, I think.
Thank you. I'll just say that there's a book some of us in my organization have read called The Paradox of Choice. And Moore is not necessarily more. No offense to Senator Moore, she's definitely more. But I mean, this is crazy. And what we know from we work very closely with the Kaiser Family Foundation. Their data shows that less than 20% of Medicare beneficiaries ever make a choice different from where they first go. And Medicare traditional program has no budget to advertise. And you may know, you know, George Foreman, Joe Namath, there's ads on TV. I'm a Medicare age. I don't get my health insurance through Medicare, but I collect these things from my mother, who's 95, and it's absurd. And since I've been working remote, at 11 o'clock most days, I get a call from someone who alleges they're from Medicare, which isn't, and I say, oh, I know a lot about Medicare, so I'd like to speak to you about that. And then they hang up. But there's huge amounts of marketing and dollars spent on that. I will tell you that the federal government just issued Health and Human Services, Center for Medicare Services, just issued proposed rules regarding Medicare Part C, which is Medicare Advantage, and Part D, which is the prescription drug program, which will roll back some of the changes that were made in the last federal administration about consumer protections. They are moving to have some more consumer protections, more distance between education and marketing, which has been blurred over the last few years.
Especially to our elders, they don't see the difference. They're getting the stuff in the mail. They're seeing the stuff on TV.
Yes,
and
they shouldn't get blind calls. They should not be getting calls. At any rate, we agree entirely, and our two attorneys in our DC office will be leading our charge and writing comments regarding those proposed rules. And we have been in touch with the Medicare director at CMS about these problems as well. More is not more, it's just too much, and it's not beneficial to people.
Thank you.
Thank you. Thank you both. We're going to move on to two more questions, and then we're going to move on to Murray Panter's presentation, because we don't want that to get lost here.
Absolutely.
Senator Miller.
Thank you. And Judy and Kathy, thank you for the presentation. I learned a lot this afternoon, this morning. So I want to ask you about Medicare Advantage. I want to read this statement. I was wondering if you could address it, and you could choose not to, which is fine. Medicare Advantage was supposed to be a money saver. It's now become costly and unaccountable cash cow for private insurance companies that is swallowing traditional Medicare. Because I'm finding that individuals, my constituents, are saying that it's unaffordable for them, and it's really not an advantage. So I was wondering if you could comment on that, if you want to. If not, I understand.
I will. The Center for Medicare Advocacy has in some ways stuck its neck out, I think, only on behalf of beneficiaries and the Medicare program. That's our skin in the game. We have no interest other than making sure that people get the services and healthcare they need, and that is legally available for coverage under Medicare, and that it's affordable for the program and taxpayers. Under those criteria, Medicare Advantage is costing us, not helping us. costing the Medicare program, and often, not always, but often not providing as much as the traditional Medicare program would for beneficiaries, particularly when people are ill or injured. It may be different if you stay well and you just need physician services occasionally. So I would urge that statement you just read is very articulate. There's objective criteria that we could point to. We write a lot about this. It's on our website. Kaiser Family Foundation, Health Affairs, MedPAC, the Medicare Advisory Commission, Payment Commission has also pointed to some of this. And I think that our congressional delegation would welcome hearing from you. There really should be a hearing about this because it's costing us billions of dollars that could go into patient care. Keep that Connecticut dollars coming so we can keep speaking truth to power,
Yeah.
please, and helping constituents.
Well, thank you for that. I appreciate it. And I would love to give you a call to talk to you about direct contracting. So I appreciate your honesty, your candor in addressing that question or that statement.
Thank you, Senator Miller.
Senator Miller, maybe we should do a joint letter to our congressional delegation about this issue. So I would love to talk to you and Representative Garibay after this meeting about doing that together. I think it would be in human services and aging. It might hold some weight. So we'll have
I
a
believe it would be
conversation.
welcome and attended to. Thank you.
Great.
Yeah,
Thank
thank you for raising the issue, Senator. That's great. Representative Vargas.
Thank you, Representative Abercrombie. I just like to say that, I'm deeply involved in this issue, and I want to thank Judy and Kathy and all the people working on this because it is complex and it's all being driven by greed. And unfortunately, we're just one small corner of the United States trying to hold on to what we can. I'm happy that we as legislators have helped to fund this organization, but it is a tragedy to think that despite the fact that we're trying to educate people regarding their rights on health care, and despite the fact that we funded organizations like this one that we're still fighting a rearguard battle. And I just wonder about states where organizations like this don't exist, what kind of abuses are taking place around our country and how we're slowly backsliding. And I know the fight is mostly at the federal level. And I know that the Advantage plans, when they first started out with the HMOs, I joined Kaiser Permanente. I thought, Ted Kennedy was making a good argument that there were perhaps unnecessary procedures, over medication, that maybe there was money to be saved for the taxpayers. But unfortunately, all that has gone by the wayside. Now, whatever savings there might have been realized have gone to the pockets of the investors in these healthcare, insurance industry that has become a giant. And lately now they also are putting forth the idea that they want to administer what's left of traditional Medicare. And if that ever comes to fruition, then there'll be a false choice between traditional Medicare and the Advantage plans, because basically it'll be one and the same outfits taking care of both for their benefit, not for the benefit of the people who are retired and fighting for their rights under the medical legislation of Medicare. I'm a supporter of a one-payer system. I would love to have national health insurance. I know that that's, not something we can resolve here in Connecticut. But I do agree that, our delegation, our federal delegation, including my Congressman John Larson and others, have been trying to throw a wrench into the system and slow down this whole system of privatization. Unfortunately, people make short-term Faustian bargains at the local level because they're trying to protect their immediate interest. But I think in the long run, we will rue the day when we abandon traditional Medicare, because if there's one thing that has slowed down the greed machine, it's the fact that there's still an alternative, no matter how tenuous. Once that alternative is gone, then you'll see that greed machine go full steam ahead. So I'm glad that so many of my colleagues are on this call because I have some bills regarding this issue. I'm a retired teacher. I've been trying to help the retired teachers, and the TRB, the State Teacher Retirement Board, has been basically stacking the deck in favor of the Advantage plans, and very misleading publications. They talk about the pros of the Advantage plans. They don't talk about the cons. They basically don't even mention the traditional plans. So I know that's a battle, and I know that we have a lot of work cut out for us. But whatever we can do here in Connecticut to help preserve traditional Medicare, I'm on board, and I hope that my colleagues will support me on these issues. And thanks again to the presenters for the valuable information they brought here before us today.
Thank you so much.
Thank you, Representative. And you make some great points about the TRB. I think we're all hearing more and more about what's going on over there. I can tell you that the chairs of appropriations are looking into it also from a financial point of view. So you might want to have a conversation with our House member, Representative Walker, about that. So thank you for that. Representative Wilson, I'm going to ask you to hold your question so that we can let our long-term care ombudsman give her presentation, because I don't want to run out of time. And then I will go to you first, sir, if that's okay with you. Thank you. Thank you. So now I have the pleasure and honor of turning over this presentation to our long-term care ombudsman, Mairead. I just want to say a few things about Mairead. We as a state are so fortunate to have her in that role. And for those of you that have not had the opportunity to have a conversation with her or go to a meeting where she's presenting, do it. Because this woman not only is great in her role, but she is just amazing at knowing this service area and knowing what's right for the constituents that we represent and where agencies can do better. So please take the opportunity to have a conversation with her. I can't say enough great things about her. And with that, I will turn it over to our long-term care ombudsman, Mairead Panther. Good morning, Mairead.
Good morning, and thank you so much, Representative Abercrombie, and for the partnership. I want to thank you, Senator Moore, the ranking members, and I see as well we have our aging chairs here and just so many legislative representatives. Having you here means so much because it shows your commitment to the individuals that we are all here to serve, right? Your constituents, my clients, Judy and Kathy. We are very, very fortunate in our state. We are small, but we are mighty. And we have seen that both here and at a federal level. The partnerships that we've developed started before the pandemic, but have definitely become richer throughout the pandemic because we've learned that we don't all have to be the experts in everything, right? I reach out to you all. I don't need to be the expert in Medicare. I can refer with good faith the individuals that we serve to the Center for Medicare Advocacy. And we've really seen how our partnerships and overlap can bring the most benefit to the individuals we want to serve. So I want to put that out there. If you have issues, questions, or concerns, always feel free. You can reach out to any of us, whoever you get first sometimes. And as I think it was Judy said, we will get it to the correct person. None of us have any issue with that. So with that, I'm going to start my presentation. I know several of you are familiar with my role and the role of our office. However, I'm sure there are some people out there that aren't as familiar. So I just want to do a quick overview, not going into great detail, but just who we are, what we do, who we serve, and you are welcome to ask questions. As the center brought up, we did do more historically with going out to education sessions and town hall meetings. We're still willing to do that and able to do that, whether it be remote or in person. My team and I are starting to do things in person again. All right. So as I think Heather's getting this going, I will tell you that our office sits autonomously within the Department of Aging and Disability Services. I think this is a really important role for our office because although it gives us a seat within state government, it also allows me the autonomy to do and advocate for what I think is right for the individuals we serve. We protect the health, safety, and welfare, as well as the rights of long-term care residents. And we bring their concerns to public officials, so to all of you, and ensure that their voices are heard outside of the walls of the long-term care community. And you all really honored that last year when you passed legislation ensuring that they have the right to testify remotely and that they will be heard on issues and concerns that directly impact their lives. As I said, we sit within the Department of Aging and Disability Services. However, we are autonomous, and that is really unique within the state system and something that here in Connecticut, I feel is honored as well as unique. In other states, we don't see things set up that way. The office is autonomous. However, they serve at the pleasure of the governor. And when this role was set up here in Connecticut, on day one of being hired, I become a classified position, which I think really helps secure that autonomy. Next slide, please. So we respond to and investigate complaints brought forward by residents, family members, and other individuals, and we work on the residents' behalf. So this is very unique, and I think sometimes people confuse our investigations with the investigations of the Department of Public Health or Elderly Protective Services. When we investigate a complaint, the first thing we have to do is go out and ask the resident if they want us to move forward with the complaint. And yes, this even includes individuals who maybe have a memory care diagnosis or maybe have a conservator. Because we work at their direction, it's really important for us to have a full understanding of what they want. Many times residents will tell us no, and we saw this really increase during the pandemic and since. The reason for that is they're afraid of retaliation. Things are very challenging at this time, and there's staffing issues, and they're afraid if they complain or bring up issues or concerns, or we respond to an issue or concern brought up by a family member, that when we leave, they may not get the care and services they require. And so that can be very frustrating at times. It's also frustrating for the long-term care providers because they want to resolve the issue. They sometimes know we're there for a reason. We try to make things as confidential as possible. We'll go to several people's rooms or see people and talk with different people to help maintain that the privacy. But when we're not able to address a concern, even abuse, that can be very challenging. So my team members will often go back a couple of times, check on the person. We are not mandated reporters. I think that that's also really important to understand. We're carved out federally from mandated reporters so that we can help ensure that residents can speak to us freely. I've included a link at the bottom of this that just talks about our programs, who we are, who we're not, and how we do our services. So we have 8 regional ombudsmen in our state. We used to have 9. We did lose 1 position. Those 8 regional ombudsmen cover all nursing homes, residential care homes, and assisted living. And they help work with individuals to ensure that their rights are protected. My role is to monitor state and federal laws, regulations, and make recommendations for improvement. I do that here at the state level within the legislative session, as well as through our state sister agencies, the governor's office. And then at a federal level, I'm really fortunate because CMA is also my partner at a federal level, and we've been able to go and speak at congressional roundtables in DC for important topics and issues that we think will benefit the individuals we serve. Next slide, please. So we protect residents' rights that are guaranteed under the federal 1987 nursing home reform law. And there's been some changes over the years. However, the basics to residents' rights have not changed. That really we want to promote and protect the rights of each resident and that they do not lose any of their rights as their civil rights just because they choose to receive their long-term services and supports in a long-term care setting. I think often, even at the beginning of the pandemic, we saw this where because someone was choosing to receive their long-term services and supports in a nursing home, we assume that they may not know what's best for them, that they can't make their own decisions, and that we need to do this for them to keep them safe. There are so many individuals that are very able to say how something is going to impact them and want to have a say in how their life goes. We had family members from across the country, my thing is not going to let me show it, put a book together called Saving Them to Death. We think that there were, you can't see it, but there were safety measures that were put in place that were very well intended, that had some very significant outcomes and impact to individuals due to their rights not being seen in a holistic way, but only from a medical way. And so that was something that we talked about a lot. And I was extremely thankful that you all heard, and you heard it from the individuals that you serve, about not just medical practice, but to have social and emotional support as well, and why that's critical. And thank you for the Essential Caregivers Bill in that. All right, so for a person living in these settings, again, they have the same rights, and the bulletin on the bottom, just so that you're well informed and you have that in your office or your aides have that. It goes over what the residents' rights are. It's a little fact sheet from the Long-Term Care Ombudsman. There's a national group called Consumer Voice that does a lot of our outreach and education, and there are some flyers there that might be helpful to you, but there is one there. Next slide, please. All right, inclusivity. Integration of independent goals and the ability to live authentically. This is something that we started prior to the pandemic. I host a group within our state. It was something that I saw when I became the state long-term care ombudsman that I really felt was needed. We had partnered as a program with LGBT aging advocacy work group. And through that group, we heard from individuals that they are not one note, right? None of us are just one thing. We're many things. And they felt that it was important when you choose a long-term care community, or really to live in any community, that they wanted to be seen for their full identity. And that feeling marginalized because of one part of who you are was just as challenging as feeling marginalized for something that might be more forward-facing. And so we have been working to put together a toolkit that will be available for free on my website for communities in order to ensure that their paperwork, how they respond to individuals, that the overall makeup of their community really meets people where they are and helps them live their best life, and that they're committed to that, and that having that the expectation through all levels of the community, we will start to see better outcomes, and we will start to see individuals feeling truly included in a holistic way where they live. So if you want more information or you'd like to participate in that group, please let me know. I will share that it is by far one of my favorite meetings every quarter. It's the most dynamic conversation. I learn things. I am not, a part of many of these groups, but it is a safe place to ask questions and to get a lot of information and see how we can do it better. Next slide, please. I just included this. This is our vision statement, mission, and goal for that group. We will share these slides, excuse me, and you all are welcome to review that. It took a really long time, excuse me, for the group to come up with this, so it's very important to me. Next slide, please. Visitation and access residents' rights. I wanted to focus on this a little bit because over the past 2 years, this is something that we've spent the majority of our time on, that residents have always historically had the right to receive the visitors of their choosing at the time of their choosing. Seeing the changes to this federally really impacted our residents in long-term care. We are still hearing about significant issues related to visitation and access in our assisted living communities because they are not protected or they don't have Medicare and Medicaid, and CMS does not give direct guidance to them. These are all contract-based living arrangements, and they put guidance in place as they see fit. And this has been very challenging throughout the pandemic and continues to be a significant area of concern. Nursing homes receive guidance from CMS, and although we have challenges there at times, I think they're trying. We've made huge steps forward. They are honoring essential caregivers and looking at how we roll that out with the support of the Department of Public Health. But for our assisted living communities, if you have them in your community, checking in, finding out what they're doing related to visitation and access, and ensuring that those individuals' rights are protected. If you're hearing concerns, please let my office know. The new changes recently to visitation related to testing, just so you know, it has been seen as a best practice throughout our country. We have other states that still are really limiting access and visitation, and having the ability to maintain that connection for family and friends has been crucial during this period of time. Next slide, please. Involuntary discharge is an area where we have seen this as one of the largest areas of complaint for our office for the past 5 years. One of the challenges we see is that residents are discharged to homeless shelters, to hotels, or other unstable housing. This is very concerning, as not only is it bad for the person, but for taxpayers. The person becomes unstable, usually very quickly, ends up back in the hospital, and we see their level of need or care increase, and they come back into the long-term care setting with more significant health issues. The state does have some new programs in place like CHESS and My Care Options. However, this is still very concerning. We have built a new portal that is an option for people to use right now in our long-term care communities. We've had a good response to it. We're hoping that the portal will help us be able to negotiate a positive outcome for the resident. So what happens is our office is required to be notified every time there is an involuntary discharge, which is basically any discharge from a nursing home, unless the resident raises their hand and says they want to leave. Currently, all that information is faxed to my office, which is challenging because I end up with lots and lots of faxed paper about what is happening to people. We've built a portal where all of that information can be gathered. We can start to look at data as to why individuals are receiving these notices, where the gaps in services are. Is it at a state level? Is it a programmatic level? Is it something the nursing home isn't doing? And really drilling down to get information to all of you so we can make appropriate decisions about what services continue to be needed within our state. There are only certain reasons why an individual can be involuntarily discharged from a nursing home. And one of those is nursing home closure, also failure to pay. When it's failure to pay, it is, if they have Medicaid, it is not the applied income portion, although we really feel residents should be paying their whole bill at the nursing home and do encourage them to do so. We see emergency cases as we have more individuals that are struggling with mental wellness. I think as many of us are in the global community today, they go into the nursing home, not being able to live the way that they have, especially during the pandemic, has caused some of those challenges related to mental wellness. And we've seen more individuals go out to the hospital because of that or have a refusal to readmit. Next slide, please. So residents must receive if it is not an emergency. Okay? If in that instance, it is not an emergency, which means they can't do something to intervene and stabilize the situation, that the resident must receive a 30-day notice. And then those are the criteria that must be in the 30-day notice. And they must be maintained at the facility. They remain there while this notice is taking place and then during any appeal. Next slide, please. This is our portal so that if you have questions from any of your care providers, we will, I've sent this out to the associations earlier this week. I just did an in-service to the nursing homes with their attorney related to involuntary discharges and wait lists and what we're looking for to ensure that people have appropriate access in a fair way to all long-term care communities. So you can send them this link. Next slide, please. All right, and this is our contact information. Also, we here in Connecticut have the Coalition for Elder Justice. We have a wonderful public and private partnership of individuals who work to ensure the safety of all older adults. And when we provide people with information and the people around them with education materials, we find that they often have better outcomes. So really working on that. And that's all I have today. Thank you.
Thank you, Mairead, and thank you for that presentation and just helping to educate all of us on what your office provides. On the involuntary discharge, just so you know, we are raising that bill again this year in Human Services, and I'm working with Legal Services right now about the language. I know that it's more of an issue for some of the other facilities, but we are trying to get the language correct. So thank you for that. With that, I'll turn it over to Representative Wilson for any questions.
Thank you, Kathy. It really wasn't a question. It's just going back to the Medicaid Advantage thing. My passion got stirred up again when Senator Miller raised her question about Advantage plans. And again, in the interest of disclaimer, I'm retired now, but I spent 40 years in the financial service industry and was a licensed insurance agent and did many Medicare insurances for my clients. I never, ever sold an Advantage plan. And the reason is they're only good for healthy people. They're not good for sick people. Don't even think about it. So that's my opinion. I'm sorry.
Don't be sorry. We appreciate your passion on it. Questions, colleagues, either for Mairead or for Judy or Kathy? So I have a couple of questions since none of my colleagues do. So my first question is, for the coding in the hospitals, outpatient versus inpatient, right? Is it a difference in the location that the person is that the hospital codes it? So for example, a lot of the hospitals have now individual rooms in their ERs. Are they considering that an outpatient code when someone's there if they don't have to be admitted to the hospital? Because I don't understand why there should be a difference in the coverage.
I'll take that. Generally, no. Usually, the patient is not in a different part of the hospital, may even be in the same room with another patient who's in inpatient, and the tray comes from the staff with the same food, well, two different servings, and they receive the same care as they would if they were billed and classified as an inpatient. There are a few hospitals that have observation units, but in general, I don't know about that room, of course, in particular at a particular hospital, but in general, what I can say is that the care is not distinguished from inpatient care. Unfortunately, observation outpatient status means that the patient might not have automatic discharge planning rights under Medicare for a variety of reasons, but the care during the stay would not necessarily be any different than if they were called inpatient. It's a billing classification.
Okay, thank you. Thank you for that. And then my second question is, are you getting any calls from our constituents that since Social Security has gone up, are they concerned that they won't qualify for MSP anymore?
Kathy, can you handle that?
I think the exact opposite. I think because the Social Security went up, the Medicare went up, an equivalent amount, essentially. Most people lost all of their increase in their Social Security to the Medicare premium increase. And so if anything, we're hoping as people call us that we can advise them to be screened for MSP, the Medicare Savings Program, to see if they can get some help paying for those costs.
Thank you, because I'd hate to see anybody lose the MSP portion of their insurance, because, just personally, I know what a lifeline it is for our families, and it's something that, I personally have fought to have an acid test and all kinds of changes that come up every legislative session. So thank you, all of you, for really validating what the importance is for MSP, and that it's not just for seniors either. We have young people that have multiple disabilities that if it wasn't for the MSP program, these are people that are on Medicare, and the MSP is a supplemental, and they would be in big trouble financially if they didn't have that support. They would not be able to get the services that they need. So, I just urge my colleagues when we talk about MSP to really educate themselves on who it protects and how important it is. So thank you both for that.
Amen.
And if
we'd be happy
if
to
I can
help in
just
that
add,
area.
because I think one of the misunderstandings about the Medicare Savings Program is that there are a number of seniors and people who are disabled who are working. They continue to work, and 50% of their money, their income that they make from working, is discounted. It's not counted within the calculation for Medicare Savings Program. So when we say people who are making less than $2,600 a month, if they're working, they can't, that $2,600 a month doesn't include 50% of their income from working. So there's a lot more people that qualify that should go through this very brief screening process to see if they can get some assistance.
I think that's a great point. Thank you, Kathy. Senator Miller.
Thank you, Representative Abercrombie. I have a question for Mairead. We have been, we've made great efforts to keep individuals in their homes instead of placing them into skilled nursing homes. So my question is, I know that there's an ombudsman for nursing homes, long-term care nursing homes, but what about the community? What about those individuals who are under home care?
It's a great question, and it has come up so much. There is not at this point. We have seen in the Build Back Better bill, which is challenging for me to say, there's a line in there that does say any state that accepts funds for home and community-based services shall have a community ombudsman. We've had a lot of meetings here within our state, and I'm really thankful for sort of the forward-thinking approach that representatives and legislative members in our state have taken to really find out what the need is, where are we seeing some gaps. The steering committee for Medicaid long-term services and supports, we have seen that. We've really encouraged people to choose to receive their long-term services and supports in the setting of their choosing, wherever it best meets their needs. And my office is one of those supports that they have, but did not follow them when they made that choice. And so we really feel that it's important, and that there should be, that my office should cover any individual who has been identified as needing long-term services and supports, and helping them understand their rights holistically related to those supports. Thank you.
Thank you for that. And I would encourage the chair of Human Services. I know that there's been a working group around this issue, and it is something that's very important, because I think that was the piece that we forgot about, that encouraging individuals to be able to remain in their homes. We forgot the services that they would need, the additional service they would need for intervention and protection. So I really do thank the Human Services chair, and I believe Representative, I call her Lucy, I'm sorry. Dathan, right. I believe she's been working on it too. So I really do thank you for your vision on that. And I'm looking forward to hearing more during the session. Thank you.
Thank you.
Senator Miller, I would love to offline set up a meeting with you and your co-chair, Representative Durabay. Senator Moore and I are very interested in this issue, and I think the time has come for us to look at our long-term care ombudsman role and to add other areas like the home care ombudsman, like hospice. How we do that, devil's in the details, but it is something that Mairead and I have been talking about. So I would love to have a conversation with you guys offline about what our thoughts are and kind of make sure that our committees are in line as we go forward, because I think the time is now. And I think if the bill back, and we know bill back is going to get funded some way, we're very hopeful that the home care ombudsman piece of it will still be in there. And now's our opportunity as a state to get that up and running. And we have ARPA dollars that we could start with until this gets done. We have $200 million, folks, that we still have for ARPA dollars. And we could start it with that. I've already talked to the chairs of approach about it and, figure out where do we go from there. But you're absolutely right. So we'll be in contact about having a meeting around that issue. So thank you, Senator. Representative Vargas.
Thank you, Representative Abercrombie. This Byzantine system of medicine in this country, which is being laid on people at the point of their lives, as been mentioned earlier, when they're in a period of cognitive decline and where they have to rely on relatives that are trying to continue their own work and they have their own family problems. We need to simplify this system. We need to make it easier, more accessible. I know people always have the pat answer, well, get an attorney, as if it were as simple as that, right? And that leads me to my question, and maybe Mairead or Kathy or one of the others could answer this question. Once decisions are made and rulings are made on these issues, does this become like case law, or do you have to relitigate this time after time?
So I will say that when we get a case, if it's related to Medicare and someone's benefit, our office, that's not something we take on. Again, we don't have to be the experts and everything. We would refer it over to Center for Medicare Advocacy and let them make that decision. So Judy.
Yes, if I understand correctly, when we handle individual cases in a Medicare appeal, for example, it has not got precedent. It's called precedent for the next case. Each case stands on its own. And that's why when necessary, and I do mean necessary because it takes a huge amount of resources, we bring these class action lawsuits because those lawsuits affect everyone in a similar circumstance. So the Jimmo case has an effect for everybody who's told that they can't get Medicare because they're not improving. The Barrows case has effect for everyone who's told that they can't, now they can appeal an observation status classification. So it depends on the individual case. If an administrative appeal decision does not affect the next administrative appeal decision, it's a little bit complex, but sometimes these cases go into federal court. And if they're at the trial court level, that's called the District Court of Appeals. Those cases can have precedential value within the district, within Connecticut District Federal Court. But you have to have a class action in order for it to necessarily have an impact on everyone in similar circumstances.
Well, that is truly sad that one case can't cite another case to resolve an issue. That is truly sad.
I agree with you entirely. That's why it takes so many resources one of the reasons, so many resources to do the work we do.
There is ignorance and then there's willful ignorance. And when greed is involved and when there's a profit to be made, people can be very obtuse. And so I'm glad you're dealing with these issues on a class action basis. Hopefully that'll help settle some issues so that they don't have to relitigate it time after time after time. And it's basically like the system is set up to make sure some people just don't exercise their rights at all. and fall by the wayside.
That's true. And I know time is short, but just let me say one more, thank you and gratitude. The Center for Medicare Advocacy is not mirrored in any other state. We have a partner organization in New York, but that's not our organization, the Medicare Rights Center.
Judy, you went on mute.
As a result, you would see that much of the positive Medicare law in federal court comes from Connecticut, and then our appeals court is called the Second Circuit Court of Appeals. So this is one of the ripple effects of the funding that we have been able to receive over the course of the life of the Center for Medicare Advocacy, which takes a great deal of resources, but it has a particular and unique impact on citizens in Connecticut. So thank you again.
And with that, it's 12 o'clock, and I think we did pretty good with staying on time. I first want to thank the Human Services Partners of AG. Thank you so much, guys, for doing this informational forum with us. We appreciate it. And to our presenters, Judy, Kathy, and Mairead, I can't tell you enough. Thank you, thank you, thank you for sharing your expertise with us and for also being there anytime we pick up the phone. Together, we can support our constituents, our aging population, and make sure, one, they're safe, and two, make sure the services that they have earned, they get. So with that, I just want to say have a great day, everyone. We are having a nursing home forum through Human Services next Tuesday. Mairead again, poor thing, is going to be presenting, but I want to thank everybody for being here and have a great day.
Thank you so very much.